You enjoyed your break. We are going to get started with our second talk of the day on our otolaryngology themed academic half day morning. We have Dr. Brittany Barber here, who is going and how to best work them up and whatnot. So thank you for being here, Dr. Barber.
Thank you for having me. Can you all hear me okay? Just give me a thumbs up if we're good.
We can hear you and see your slides.
Yeah. So thank you for being here this morning. I apologize about the date of this. I have altered this a little bit for your guys' purposes. So I thought rather than try to discuss this quite diverse pathology of head and neck cancers that we see above the clavicles, I thought I would start with something that might be a little bit more applicable to you guys, which is just a neck mass, and then how those can sort of transition into other types of cancers and how we work them up when we just get kind of a very straightforward neck mass. A couple of objectives for the talk today. So to discuss the appropriate workup of neck masses that you guys might see in your clinics or on the ward or, you know, in just in general, and then to discuss the different etiologies, and then to see some of the diagnostic dilemmas that might actually land in your guys' lap before the patients make it their way to us. And then lastly, to kind of talk about two cancer epidemics that we're seeing in very young patient populations that you might encounter. So just a quick introduction. This is the group over at the university that deals with most of the lion's share of the head and neck surgical oncology cases. On the left there is one of my partners, Dr. Holton. On the right is our fearless leader, Dr. Futran, the man himself. And then 2 feet shorter in the middle, hobbit-sized, is myself. And we do most of the free flap reconstruction, most of the robotic surgery, and then some of our other colleagues in laryngology and other subspecialties, rhinology, will do some of the other types of head and neck cancer. When they get to a certain size and they require reconstruction, we usually will take care of it. These are the centers that we work at. Of course, we have a lot of patients that come to us through Seattle Cancer Care Alliance, and we have some ongoing collaborations with some much brighter and shinier people at Fred Hutch Cancer Center. So we're very lucky to have a great team between those centers. We also have another surgeon over at the VA named Dr. Risby. So head and neck cancers, they are very diverse. There is a lot of them. So trying to cram them all into one 45-minute talk is pretty difficult. So we see skin cancers, oral cavity cancers, oropharyngeal cancers, laryngeal cancers, nasal cavity cancers, salivary gland cancers, thyroid cancers. And that doesn't include the weird and wonderful sarcomas, odontogenic carcinomas, and other weird things that we are lucky to take care of, with being kind of one of the main centers that takes care of the WAMI region. So as you can see, the anatomy above the cricoid is more complicated than most of the anatomy below. We're very, it certainly presents some challenges to us surgically, but this is the general area that we take care of. And we have a lot of different technologies that help us out with that. Obviously, everybody's very impressed by robotic surgery, which is pretty fun to do, but is just another approach to the head and neck, as well as endoscopic surgery, which some of my colleagues in rhinology are part of. And then just good old-fashioned cold steel is another technology that we use. So I'm going to start out, I'm going to give you 2 cases today. The first case is an actual patient that I just operated on a couple weeks ago. This is a 35-year-old male, lawyer, 4-week history of a left neck mass. He's had 3 weeks of antibiotics by his PCP, and he's had no other workup. And he presents to you because he feels that things are taking too long to get to the bottom of this. He wants a real answer. So a couple of things to talk about on history. You all know how to take a history, probably a lot better than surgeons do. And basically he says, well, I thought it was something to do with COVID. So I thought I'd come into the hospital and get it sorted out, which is, everything is related to COVID these days, of course. And it's been around for about 3 weeks, but he says he's sure that the antibiotics made it better, which is a common story that we hear. He has no associated symptoms. He says he's fine. He's got no fevers, no night sweats. He's not having any difficulty swallowing. This thing just showed up one day and he just noticed it while he was shaving. So you ask about other things, did you get bit by a human, bit by a cat? Is cat scratch disease? Is it travel? Is it trauma? Any of those things? And he says, no, there's nothing. And he's not a drinker or a smoker. He's not immunocompromised. He has had no previous history of radiation exposure. He's had no previous cancers. He's He works as a lawyer, so he's basically kind of been working at home during COVID. So other review of symptoms, he's had really none of these things, but all of these things you would ask about, of course. So dynaphasia, dysphagia, voice changes in particular are of particular interest to us, and shortness of breath, but he has none of those things. So you decide to do a complete head and neck exam, and that includes looking at his mouth and looking at the back of his throat, so oral cavity, oral pharynx. You look in his ears because you guys are great and you're usually pretty complete about doing those things for us, which is wonderful. And you do a cranial nerve exam, scalp, face, and ectodermal exam. You look at everything because you don't know what this is from. A thyroid exam, and you go ahead and kind of notice a couple things about that neck mass. So you note the size, the location, the pain, mobility, overlying skin changes. And before we get into his findings, we'll just talk a little bit about different lymph node basins, because this is pretty important in terms of, from a head and neck surgical oncology perspective, it really points us in the right direction when we don't have an obvious primary cancer. So we'll talk about what his findings are in just a minute, but just very briefly to talk about lymph node basins. These are separated into 6 nodal stations. There is a level 7, but that's down in the chest, of course. And level 6 is anterior and kind of difficult to see in this picture. The reason that these lymph node basins became noted is kind of back in the 70s. And the reason for that is that primary cancer lesions, we know, can kind of be categorized into presenting with these different lymph node stations. So for example, a level 1A you can see is just right at the anterior portion, right below the jaw here. And that typically indicates that there's a cancer in the anterior floor of mouth, or a problem, cancer, inflammation, infection, in the anterior floor of mouth, from the mandibular incisors, the tip of the tongue, the chin, or the lower lip. Level 1B generally is just for all oral cavity, floor of mouth, oral tongue lesions. And then you can see some nasal cavity, maxillary and frontal sinus, ethmoid sinuses, and facial skin lesions that drain to that location as well. From there, we go to level 2. And level 2 is really a catch-all for a lot of different primary sites in the head and neck region. It primarily is common things being common, will drain the oral cavity and the oral pharynx, but you can see lymph node metastases from all of these other sites in level 2. So this looks at exactly where his location or where his lymph node metastasis is, and is a very common catch-all for a lot of different cancer lesions. Now, just to kind of really touch on this, because you hear me making the distinction between the oral cavity and the oral pharynx, you know, in case this is unclear, these are kind of the delineations between the nasopharynx, the back of the nose, where the adenoid is, the oropharynx, which encompasses the soft palate, the 2 palatine tonsils, the base of tongue, and the lateral pharyngeal walls. And then the hypopharynx, which is really the larynx and the hypopharynx. Larynx being here anterior, voice box, and just below the glottis here. And then a hypopharynx, which is kind of basically the area right above the cervical esophagus. Now, level 3, we start to see things move a little bit lower down. So most commonly, if you were to see a primary lymph node metastasis in level 3, you think about things like the larynx, the thyroid, or neck skin. And at level 4 tends to be more focused on the hypopharynx, larynx, and thyroid. And then, of course, down in level 4, if you see an isolated node in, say, left level 4, I've certainly seen patients send those, or people send patients to me with an isolated left level 4 node that they thought was either a lymphoma or an unknown primary. And of course, in that location, you have to start thinking about a Virchow's node, which is indicative of an intra-abdominal malignancy that's traveled up the lymphatic channels to level 4 on that side. We don't see it on the right side, really just the left side. And you guys have probably seen that before from your surgical rotations in med school. And we can see some intrathoracic malignancy spread to level 4 as well. We also can see lymph nodes, or sometimes patients will present with a very firm node down low in level 4 that's actually part of a very large anterior mediastinal nodal conglomerate as part of a Hodgkin's lymphoma. That's common as well. Level 5 is more posterior triangle here, and so most of that's going to be the nasopharynx, posterior neck and scalp, the parotid, neck and facial skin, or the ear. And then level 6 is usually the thyroid, but can be the subglottis of the larynx, and then these other lower down hypopharyngeal and cervical esophageal lesions. So you do your physical exam, you assess all of these things as we mentioned, and this is his history again, and his exam shows that he's got a level 2-3 neck mass that's about 2.4 by 4 centimeters. It's relatively mobile. There's no changes in the overlying skin. and there's no other suspicious findings on oral cavity exam. And he tells you that, you know, his PCP arranged for him to get an open neck biopsy by an outside surgeon next week, and he wants to know what you think about that. So we're going to talk a little bit about whether that's a good idea or not. Now, you guys have all seen this terrible acronym, Vindicate, which is a really good acronym for being very complete when it comes to neck masses. You can kind of separate these things a little easier into non-neoplastic, neoplastic, or congenital and acquired. And I tend to use this kind of slightly more abbreviated abbreviation here when I'm looking at these things. And so congenital or acquired kind of depends a little bit on the age of the patient, though we can see branchial cleft cysts that we can't distinguish from cystic nodal metastases. And so I will talk about that in just a moment because it does present a bit of a diagnostic dilemma and it will be part of our case. These other things, langreceals, dermoids, lymphatic malformations, those tend to present young. On the acquired side, you have all of these inflammatory illnesses that can present with cystic nodal metastases and can be difficult to diagnose, but generally are diagnoses of exclusion. So once you have ruled out that it's not a cancer, then we start going down this road. And often for these things, particularly things like Castleman's or Rose-Dorfman, we have to do open neck biopsies, but that is a last resort after we've definitively ruled out cancer. Infectious, don't forget about HIV because we do see that frequently. HIV will see we'll see enlarged lymph nodes, but we'll also see lymphoepithelial lesions in the parotid. Don't forget about TB. Those are all things that with a particular history you might find, or even without a particular history. Certainly HIV does go on underdiagnosed. At least I've seen that in my practice. And then vascular, this is something that's important. We'll talk about this in just a second. You want to make sure that this outside surgeon isn't going to go in and just pop this thing out, but it's actually carotid body tumor. That would be not the best approach to a carotid body tumor. And then neoplastic things, and we'll talk about that here shortly. You have both benign and malignant lesions that you can have. Now, your acquired cancers for malignancy, they can be any of those things that we've already talked about. And in terms of the most common thing for a 35-year-old male with a level 2-3 neck node, it's going to be one of these 6 things, common things being common. So that's what we're going to focus on ruling out here. So what do we want to do next? So our initial diagnostic workup, you know, often you guys are very kind to us. You'll go ahead and order these things. We are certainly capable of doing our own FNAs, which in some case can be advantageous because we can order the things that we want and often save the patient a second FNA. But regardless, any kind of workup that you guys do is really appreciated. CT neck is often the first thing that we'll start with. And we're going to talk about a couple of these things. So why do you probably want to refer him to us with a neck mass like this? And which diagnostic studies should be ordered first and why? And why should he not get an open neck biopsy that he's telling you he's already got scheduled? So why does he need flexible laryngoscopy? Well, for a number of reasons, and we're going to talk about these coming up. You know, with a neck mass, often the first presentation of oropharyngeal cancers, so this is the base of tongue that you're looking at there, the epiglottis more posteriorly, and you can just see the tip of the uvula at the top of the screen there. Oropharyngeal cancers can present with a very, very small primary lesion in the base of tongue, the tonsils, the soft palate, or the lateral pharyngeal walls. Very small primary, but with very large nodal burden in the neck. And that's a very consistent, reliable presentation of HPV-related disease. And so laryngoscopy is necessary to see if you can identify that very small primary. This is a normal oropharynx. It's also necessary if this is thyroid cancer, you have to rule out that there's any recurrent laryngeal nerve paralysis. Now you might be saying, well, his voice was normal, so you think you would hear if there was any paralysis. You can have paretic vocal cords that don't present and don't show themselves with the voice because the vocal cords can compensate. And so you wouldn't notice if the patient went for thyroid surgery, whether their vocal cords were paralyzed prior to the surgery or after. So that is important as well. You need to rule out that there's a laryngeal cancer here, a hypopharyngeal cancer. And then lastly, if you don't find a primary site, then you need to rule out that you can see one, and that's possibly a carcinoma of unknown primary, which we'll talk about here shortly. So this is a very small midline base of tongue cancer. You can see just low down here at the center, right anterior to the epiglottis. This is a laryngeal cancer. This one would have voice changes. You would certainly see that. And this is a hypopharyngeal cancer that's creeping up onto the area epiglottic fold of the voice box there. Generally, yes, you would have some voice changes with this, but when these are slightly smaller than this lesion here, you may not have any symptoms at all other than very mild globus sensation. So which diagnostic workup should be performed first? A CT neck. Now the reason for that is that this could very well be a carotid body tumor, and you don't want somebody sticking a needle in this, or you don't want to even refer this on to IR. They will do their ultrasound, prepare to do their ultrasound guided FNA, find out that it's got vascular features and tell you, we're not doing that. And then you kind of, the patient's finding out from the interventional radiologist that they've got a carotid body tumor. So usually you want cross-sectional imaging first. And this is an example of what we call a Chamblin 3 carotid body tumor there, kind of a larger one. So you get your CT neck, and this is an actual CT of a patient of mine that I operated on a couple weeks ago. It's a fairly large mass. It's 4.2 centimeters. You're just seeing the top of it here. There's multiple calcified thyroid nodules, they tell you on the CT scan, but of course CT is not the best way to evaluate the ultrasound or the thyroid, we all know that. And there's no obvious primary lesion identified by the radiologist. So you go ahead and you get an ultrasound thyroid because you hear about these calcified thyroid nodules. And he's got a TI-RADS 4, you might have heard of this radiology classification for thyroid nodules, a TI-RADS 4 1.6 centimeter nodule. Not to get into it, of course, but that means this gentleman needs an FNA. That meets criteria for FNA. That guy right there. So you refer on to us very kindly for an FNA and flexible laryngoscopy. Why? Again, to rule out oropharyngeal primary cancer, to ensure there's no recurrent laryngeal nerve paralysis, and of course to rule out any other laryngeal hypopharyngeal cancers. FNA of the neck node is done with thyroglobulin, also with HPV in situ hybridization and P16 immunohistochemistry washout. Why do we do that? This is a very cystic node. Often with cystic neck nodes, we'll FNA them and they'll come back as either indeterminate or they'll say inflammatory cell debris. With a node that looks cystic like that, we can't just stop our workup at that point. We have to really rule out that there's a cancer there, because we know that both thyroid and oropharyngeal cancers can present with cystic neck nodes. So can other things, but those are the two most common things in the head and neck for sure. So you can do thyroglobulin washout, and that can point to thyroid cancer. You can do P16 or HPV in situ hybridization, which is a little bit more difficult to get, but the P16 is easy to get. A washout on the cystic nodal fluid, and that can point to oropharyngeal cancer. And of course, you can do an FNA of the left thyroid nodule as well with molecular testing. Why do we do molecular testing? You get indeterminate cytopathology a lot of the time, AUS, ATV of unknown significance, or follicular lesions of unknown significance. And so doing ThyroSeq at the time can identify genetic mutations that are associated with thyroid cancer and point us in the right direction. Unfortunately, sometimes if these patients have FNAs at outside institutions, they will not do this molecular testing. The patient unfortunately gets an indeterminate cytopathology, and then they have to undergo a second FNA with ThyroSeq. So it saves them some money. It saves them a second biopsy. It can save them, a bit of inconvenience and a delay in treatment time. So that's why we order molecular testing. It can often save the patient non-essential diagnostic lobectomy. So this is laryngoscopy here. And so while this is not a wonderful shot of his endoscopic picture, there's no primary lesion identified. If you look here, you'll see the base of tongue here, you'll see the epiglottis here, and the vocal cords will be back there. No primary lesion, interestingly. The FNA of the left neck node comes back, and it shows that the thyroglobulin washout was not high. It does not confirm a cancer though, because it's cystic, so it just says inflammatory cellular debris. But the P16 immunohistochemistry is positive in greater than 70% of cells, interestingly. The FNA of the left thyroid nodule shows AUS, very common, but the ThyroSeq is negative. So what does all this mean? What does it all mean? It's pretty subspecialized, so I apologize for that, but this is reasonable to think this might fall in your lap at some point. The likelihood is this is a oropharyngeal origin carcinoma of unknown primary or an oropharyngeal cancer we just can't see yet. And what are the next steps? Well, with most carcinomas of unknown primary, we just get a PET, right? A PET is great. It will show us usually where the primary lesion is in up to 30 to 50% of these cases. Unfortunately, without a cancer diagnosis, insurance will not pay. And so the patient, if they don't have a cancer, and this is simply a branchial cleft cyst of some sort, they're going to be stuck with a $2,000 to $3,000 bill because insurance will not reimburse for that. So we can't get a PET yet. So instead, we're going to take it out and we're going to do a proper neck dissection at the time with frozen section of the node. And if they confirm cancer, we complete the neck dissection, a good oncologic neck dissection, not an open neck biopsy. The reason that we don't do open neck biopsies, and the reason that it is a bit frustrating to us when patients present having had an open neck biopsy, is that there's potential for seeding of the squamous cell carcinoma to the skin. And that, unfortunately, a lot of the data from that comes from 2 decades ago. But because we don't have good data about whether or not it's possible to seed the skin or whether or not it's more likely to impart recurrence if they have had an open neck biopsy, we have to radiate these patients if they've had a violated neck before they have an appropriate oncologic neck dissection. And so that just automatically buys the patient's radiation after surgery, which is a shame if they don't need it, because that's 6 weeks of radiation that they didn't need. In addition, if they've had previous surgery, by the time they get to us, they're just at the point of maximal scarring. And so it makes the surgery a lot more difficult. Not an issue if here at the university, we get a lot of revision neck dissections, that's not a problem, but it's not optimal for the patient. So open neck biopsies can seed the skin, they buy the patient radiation, makes our surgeries a lot more difficult. So not optimal and not preferred most of the time. So let's talk a little bit about oropharyngeal cancer. Traditionally, about 3 decades ago, most of oropharyngeal cancer was caused by tobacco and alcohol use. And so this is the traditional head and neck cancer patient that you guys might have read about or known about from, the patients that don't do well, that have these big invasive surgeries. That was the previous patient population. And generally it was observed in smokers and drinkers aged 55 to 75. It was generally treated with very invasive open book surgeries like this one here, where we have to split the jaw, and then chemoradiation afterwards. The morbidity was high for these patients and their 5-year survival was on the order of about 50 to 60%. So not great. And the surgeries, continued to get more and more invasive after the first one if they recurred, which they did most of the time. Today, about 70 to 80% of these cancers are HPV related, and their survival is markedly improved from the non-virally mediated type. The incidence of HPV-related oropharyngeal cancers increased by about 225% over the last 30 years. You can make your own deductions about why that might be. Certainly an increase in testing and appropriate diagnostics to reveal HPV-related versus non-HPV-related oropharyngeal cancers is part of it. But most certainly this is probably due to changing sexual practices. Most common HPV-related malignancy now, it has overtaken cervical cancer as of 2018. And it's going to account for almost 50% of all the cancers that we see in that big list of cancers we treat by 2030. So it's certainly something that you will encounter at some point, even being in internal medicine rather than surgery. So the treatment of this, typically if it's early stage, is, we do a very fancy robotic surgery. And if it's late stage, generally they'll get chemoradiation therapy. And, we don't have to go into this, but really the reasons for that are basically that we try to save the patient larger doses of radiation, and we try to save them chemotherapy. And we try very, very hard not to treat them with all 3 modalities. So we try hard to only treat them with 2 of those 3, either chemoradiation or surgery and radiation, or optimally in early stage disease, just surgery. So this is kind of what that setup looks like. This is this very expensive robot that is only made by one company essentially, and so they have an absolute monopoly on the market, which is terrible. But it's a very nice minimally invasive approach. Carcinoma of unknown primary has a very strong, in the head and neck area, has a very strong association with HPV-related oropharyngeal cancer. So to put that more plainly, if a patient presents with a neck mass that appears to be a cancer, more than likely the primary lesion is going to be in the oropharyngeal region. It just hasn't been diagnosed yet. So that's about 90% of these patients. Other unknown primaries, they can be skin related, and certainly you can have P16 positive cutaneous squamous cell carcinomas. I had a patient that had carcinoma of unknown primary with bilateral parotid cancers and neck nodes on both sides from what was likely a squamous cell carcinoma that involuted. And so these things can happen for sure. Most of the time, these patients will present with a neck mass without an obvious oropharyngeal primary site. And this is not, unfortunately, something you guys would be able to see, even if you did a very complete oropharyngeal exam. Sometimes it's just within the tonsil, a small primary within the tonsil that you can't see. The theories about why they might have a true unknown primary and that we absolutely can't find a cancer even on the PET scan is that, regression of the primary cancer, in that, basically the body just fought off the primary cancer, but not before it metastasized to lymph nodes, or it's very small on the order of millimeters and we just haven't found it yet. And so when that is the case, it requires a surgical workup. In either of those cases, it requires a surgical workup, transoral robotic surgery. So Mr. G goes ahead, he gets a pan endoscopy, which is basically where we do a really good look and feel at the base of tongue, the palatine tonsils, the soft palate, and in all those different spaces, the nasal cavity, nasopharynx, oropharynx, larynx, hypopharynx, all those areas, and then of course the esophagus. And it reveals no primary lesion. We go ahead, we take the node out, we send it for frozen section, it comes back a squamous cell carcinoma, and we perform an oncologic neck dissection as a result. So at this point, because he has a cancer, we are now able to get a PET. And this shows just slightly more FPG avidity in the left palatine tonsil, though you did not see a mass on your exam. It has no CT correlate. So he gets this surgery here, robotic radical tonsillectomy. We don't have to go too much into detail about that, but basically, he has excellent final pathology, very early stage disease, and he will get radiation, unfortunately, because he's got 2 nodes positive. His prognosis will be excellent. The prognosis of early stage oropharyngeal cancer always is generally, and 92% of them will be disease free at 24 months. Generally, there's about 7 to 8% of these patients that are bad actors. So they don't present like the normal, very good prognosis, excellent response to chemoradiation or surgery. And they present oral cavity cancers, which are a little bit more difficult to contend with. And we don't have a lot of information about those patients yet. So most of our studies have shown that genetically, they're very similar to oral cavity cancers, even though they're virally mediated. So there's still a lot more work to be done on that. And in turn, a lot of trials are ongoing using neoadjuvant immunotherapy in these patients to see if you can actually get it to completely eliminate the cancers altogether and obviate the need for surgery, chemoradiation altogether. So, so stay tuned for that. Now, I want to go through another, so that's kind of the first epidemic. Again, as I mentioned, that is not a small increase that we're seeing in those types of patients. Even in the Washington State region and the WAMI region itself, we've seen a large increase even over the past 2 years and even this year with COVID. Despite most cancer diagnoses being delayed, we have still seen a very large number. So it's increasing in this state in particular. I will say that type of cancer presents in all different types, but it tends to be a lot more prevalent in higher socioeconomic status patients, of which we have plenty here in the King County area. So be on the lookout for it. Now, Mr. A is also a patient of mine that I operated on about 6 weeks ago. He's a 34-year-old male, father of 2. And he presents, he's had about a 4-month history of a left exophytic oral tongue mass. And he was seen by his naturopath, who told him that he had a vitamin D deficiency. So he was treated with a couple vitamin C infusions and was given vitamin D tablets for 6 weeks. And that did not do anything to this mass. So he was referred to you and to an oto at an outside hospital after 6 weeks due to lack of improvement in his symptoms. And he wants to know what's going on. So he's got a very benign history. This thing has been intermittently bleeding, and there's a little bit of pain with eating, but otherwise he's had no other symptoms, no weight loss, no rheumatologic symptoms, no joint pain. He does have a history of hypertension, probably because he's got 2 young kids at home. And he's got a history only of colorectal cancer in his 80-year-old grandfather. And he's a never smoker, and he very, very rarely drinks because he doesn't have time because of his young family. He had the Oto at the outside hospital biopsied him twice. And the results just said pseudoepitheliomatous hyperplasia and inflammatory changes. And so that fella just said, okay, good, it's not cancer. So just see your internal medicine physician and see if you've got a vitamin deficiency or like a rheumatologic disease or something. So he comes to you, and you, having seen this lecture, decide to order imaging, even though he's got negative biopsies. So you order imaging, and it shows a 2.7 centimeter area of enhancement within the right oral tongue, with slightly prominent reactive lymph nodes in levels 1A and B, as would be expected bilaterally. And so what are you going to do? Well, you see this mass and you think, that looks very suspicious, even though those biopsies are negative. And so you decide to kind of look up the literature on this. So oral tongue cancers in young patients is also increasing on an epidemic-like scale and has been somewhat overshadowed by the increase in HPV-related oropharyngeal cancer. Interestingly, that is likely just because of the demographic. And so this has also been occurring over the last 3 decades, and I'll show you some literature about that here shortly. But we don't actually have an etiology for it yet, which is why it's somewhat been overshadowed by the HPV epidemic. And HPV itself already has a lot of awareness because of cervical cancer, and so for that reason, we think the awareness around oropharyngeal cancer has been positively increasing over the past 3 decades. Still not quite there yet, but has been getting better. The knowledge about oral tongue cancer in young patients, however, has not. And so for that reason, this patient was one of 3 that I saw with very similar stories over the past 3 months. I had another 36-year-old female with a very similar story who was also treated with vitamin D for about 6 weeks and then sent to me when she had a very large fungating oral tumor. So this oral cavity cancer in non-smoker, never smoking, not drinking patients has been increasing in incidence in this age group, 18 to 44 years, with the high propensity in Caucasian males and females and higher in females, so with an annual percentage increase of 4%, which is absolutely wild for cancers. So it's a very large increase. That's been shown not just in the United States, but all over the world. 22 cancer registries globally have shown this, 9 of which were in the US. But essentially, most of it has shown that it's mostly in Caucasians, mostly in females, but also the increase has been seen in males as well, and it's been seen in this kind of under 45 group. There's no obvious geographic trend. Obviously, in places in India, there's certain practices that will give rise to oral cavity cancers, betel nut chewing, reverse smoking, those sorts of things. But there's no obvious geographic trend. The only places of those 22 cancer registries that showed a decreasing incidence in oral cavity cancer was in the Nordic countries. So we don't really have a good reason for why it is. And in terms of the etiology, there's multiple theories, mostly thought likely to be microbiome related, but there have been a number of studies that have looked at virally mediated cancers known oncogenic viruses and have not shown a correlation, and has been shown time and time again that this is not related to HPV. So we think it may be bacterial. And there are other exposures that may either be the primary cause or may influence the microbiome. And so often, because it's been female, predominantly seen in females, there have been some queries about whether this may be related to oral contraceptives or hormone related. And unfortunately, that's also been shown not to be the case. And it wouldn't make sense because a lot of it's been seen in white males as well. But there are a number of different etiologies that have been brought forward. Genetically, there are some implications for HLA-B27 patients, but at this point, the jury is still out. We have been seeing an increase in the use of vape pens, and so overall, oral cavity cancer in young smoking or never smoking patients is on the rise and will be on the rise more with the increased use of vape pens. So you very kindly refer him again for another repeat biopsy, and this biopsy demonstrates squamous cell carcinoma. And the reason for that likely is that the previous biopsy was probably not deep enough. This is a fungating necrotic tumor, as you can see here on the scan. And so sometimes there's a reticence to biopsy deep in the tongue for fear of bleeding. So this is a common scenario that we see. And so that's a smart thing to refer on for a repeat biopsy. His distant metastatic workup is negative. And for these patients, unfortunately, even though they're young and they're never smoking, their prognosis is not different than those that are smokers and are older patients, most of the time accounting, of course, for other comorbidities. Unfortunately, a lot of the times these patients are misdiagnosed, and so they present late, like these two patients did. And so surgery is the primary treatment that is preferred and has the best outcome for these patients. And they'll get a hemoglossectomy right neck dissection and usually reconstruction with a free flap. And adjuvant radiation will be given for any positive nodes, any high-risk features on the tumor, any large tumors, any positive margins. So just an example, this is not this patient, this is another patient I think I took care of a couple years ago that I just happened to take good pictures for. And so you take a piece of tissue from the forearm and a artery and a vein and you hook it up in the neck and Bob's your uncle, you have a new tongue here. And this is a similar example for a patient that has a similar problem, only this cancer invaded the gingiva on that side. And so she got a fibular free flap, which is where we take a bone from the leg and reconstruct the jaw and the oral tongue at the same time. And she eats and drinks just fine. And I saw her just last week. So for Mr. Adams, our 34-year-old father, too, his final pathology revealed a fairly large tumor, but with negative margins and no high-risk features. And even though he had no nodes positive, he's unfortunately going to need radiation. So just in summary, I think we're a little preliminary here. These are two epidemics that we're seeing in young patients. And remember that, as young people yourselves, you probably would recognize that these patients are caregivers for two different generations. They're caregivers for young kids and also older parents. They also are usually hold down jobs and have people to take care of and a family and a household to take care of. And so it's really important to try to recognize these patients, to try to make sure that they get the appropriate care that they need. Knowing where these neck masses are presenting can really give us clues as to where to look for cancers in these areas. And so whether it's an oropharyngeal cancer, an oral cavity cancer, or a thyroid cancer, getting an appropriate workup is very important. And usually that involves a CT neck, flexible laryngoscopy, and an FNA. Newer imaging and surgical technologies can help us decrease the morbidity for these patients for sure. So, PET scans have helped. Robotic technology has certainly helped in decreasing morbidity. And, lastly, trust your instincts. And I think you're all being trained in a great program. So you're going to know well what to do. But when it looks like cancer, it's not cancer until it's really not cancer. So you get the idea. Thanks so much for listening to me chat here this morning. Hopefully that was somewhat applicable to you guys and not too surgical. And of course, I'm more than willing to answer any questions that you have. I see that there are some questions here in the chat, so I'm happy to address those.
Yeah, I think the last 4 questions in the chat are the main ones that have come in, but would love to hear your thoughts on those. And I can read them to you if you don't see the chat or if you're able to read it, and that's fine too.
That's a great question. So from Nina, she's asking if you should order a CT neck with contrast. Yes, absolutely. CT neck with contrast is preferred. If a patient has a contrast allergy, that's a tough situation, but CT with contrast whenever possible. So if it's not something that's gonna be anaphylactic, if you can just treat the allergy, that's preferred. Usually we can't tell a whole lot from a non-contrast CT. So for suspicious tongue lesions, so absolutely, we get a lot of referrals for just anything on the tongue that people are just not sure about. Luckily, like I said, you guys are trained very well. So when there's a fungating oral tumor there, it's rare that we see that the patient gets bounced around. Usually will send to us right away. And any of the ENTs are fine, but most of the time they need a biopsy. And so myself, Dr. Futran, Dr. Holton, most of the time it'll go to us or our fellow. If it's a small tongue lesion that looks not that suspicious, that you're not really worried about, but you just need some reassurance, it's still fine to send to us. We would rather see it, biopsy it, and make sure it's nothing. And we'll never be annoyed if you send us something that's not a cancer. So yeah, oral HPV screening, that's an excellent question. Thank you for that question. So right now, our governing body, which is the American Head and Neck Society, recommends against oral HPV screening. I just gave a talk on this about a year ago. And the reason for that is that unlike for cervical cancer, where there's a pre-malignant lesion that can indicate spread and progression to cancer, we don't have that in the oropharynx. And so all that happens with oral HPV screening is that it may show that there's oral HPV, but it doesn't indicate that there's cancer there. And often within 18 months, about 80% of those patients will clear that infection. They may get reinfected at some point, but they often clear it. And women in particular clear it well. Men don't clear it quite as well, and they don't clear it as well as if you smoke either, or if you've had more than 6 partners. So I've had patients refer to me before with positive HPV in their oral cavity, and they come in, they're just vibrating, but it doesn't indicate that they have cancer. They're probably going to clear it. And even if they don't clear it, we don't have any indication that they're going to go on to develop cancer. Right now, our best study, because we don't have enough years of study on this, shows that even if they're male and they smoke and they have high risk sexual behaviors, their lifetime incidence of getting this cancer is still only about 0.13%, so still low. So in general, I recommend against it because it just makes the patient anxious. We can't tell if anything's going to happen, and it costs them a lot to keep getting screened. So that's a great question. Yeah, lymphedema, that's a great question. It's an important question, certainly. So unlike in the axilla or the groin, when we do a neck dissection, patients actually have a lot less lymphedema than in those sites. It has a little bit to do with the number of lymph nodes in the head neck area. So for example, in the head neck, there's about 200 lymph nodes. So taking out 40 is not a problem. The lymphatic fluid will just find another way to drain. In addition, the head neck is at the very top. There's plenty of gravity dependent drainage that can assist with that. So the lymphatic channels form a bit quicker. And even after radiation, often these patients have just slightly more lymphedema, and it certainly does not compromise any of their function at all. The worst that happens is they're a little upset that they have slightly more of a turkey neck, which is what happens when you have such a good prognosis. You worry about the turkey neck. But in answer to your question, not a problem at all. Any other questions, guys? It was a lot of information. And hopefully you got a little bit of thyroid cancer in there, but thyroid cancer can present like this most certainly, and is a whole other talk, and I'm happy to give that at some point as well.
Great. Well, thank you so much. That was really great. And thank you for highlighting the demographics of this too. That wasn't something that I feel like is highlighted for us a lot. And we all kind of have a different picture, I think, of head and neck cancer than you highlighted. So that was really helpful. Everyone, we will take a break until 10:45 when we'll come back for our third talk. Interns, it is time for you to head off to intern report, and I will put the link in the chat for you in just a moment if you don't have that. Thanks again, Dr. Barber.
Guys, take care of yourselves.